Good morning, my name's Paul. I'm the clinical instructor for the ICPs with St John NT. This morning we've actually run through an education session associated with Irukandji Syndrome. So what I'll actually show you first up is I'll actually show you the board in which we actually utilise so that you can actually see some of the stuff we've actually been discussing. So on our board here, I'll just actually take the camera off and I'll actually move it a little bit so that I can move the camera itself. Alright, so on the board here, just for your information, is all the information that was actually discussed by the team, the crew that actually came in this morning. So we talked about the case being a 27-year-old male that actually came out of the East Point area in Darwin. He's actually walked along the mango walk that's actually available there. 20 minutes after he actually came out of the water, he actually started to actually experience some increased agitation and some strange behaviour, and he actually had pain everywhere. In discussion with my crew that actually attended this morning, they've actually identified a number of provisional and also some differential diagnosis. And they actually mentioned here is the potential for a diabetic patient, but it was also realised that this patient actually had some pain everywhere and a right leg pain, in the sense that the diabetes is not going to actually cause the patient actually have that sort of pain. There was a moment where they were actually talking about different types of stings and how those stings may actually be associated with this pain this patient actually presenting how it actually did. Pharmacological interventions in the sense of pharmacological overdoses and illicit drug usage. Mental health status that actually did, maybe some TBI, have the patient actually gone through an area where they may have actually had some issues associated with a fall. Is it an allergy and anaphylaxis to the patient? Again, we actually go back and actually that may actually not show in the sense of the pain everywhere and the right lower leg pain. Could it have actually been seizure activity? Could it have actually been a snake bite of some kind where your patient actually hasn't actually realised they've actually been tagged by a snake? We actually have the mention of heat stroke. Heat stroke actually can actually cause the pain everywhere associated with it. And we actually went down the lines of actually thinking along the lines of a sympathetic overdrive, the sympathetic overdrive associated with agitation, increase in heart rate, increase in blood pressure, a headache that's actually increasing. We went through our primary survey and identified pulse rate of 136, BP of 210 on 120, respiratory rate being 32, temperature 38.1. Patient actually was exposed through the primary survey and actually identified that this patient actually had no whelps anywhere, but actually was flush. The skin was actually flush. So when we actually talk about it is that there are a number of different areas where we actually go down the forms of treatment, etc. We looked at actually identifying droperidol as being maybe an option. We're actually looking at ketamine as actually maybe an option. It was suggested that we actually go through and actually utilise magnesium. We're talking about penthrane, IV morphine, IV fentanyl associated with analgesia and also GTN. It was actually suggested we utilise the urine and also vinegar. Now I'll go back to that in a moment, but if you just bear with me, I'm just going to flip the board. So the information I actually put up on the board was for those that actually attended, and we actually ended up actually identifying this was an Irukandji Syndrome. Irukandji Syndrome associated with a presynaptic sodium channel influx or agonist inducing a massive catecholamine release. This is where we're actually getting our heart rate increase, our blood pressure increase, our headaches associated with it, also the respiratory. And also remembering is that if you actually have an increase in catecholamine release, you're going to actually have an increase in metabolic processes as well. When we talk about this patient is actually presenting with symptomology associated with severe pain in most body regions, even though that actually may be a localised area for the sting, either arm, leg, wherever it is, across the torso. This patient actually has some severe agitation and distress, which may actually be difficult for you to actually manage because the patient is in so much pain. Is this because the patient actually needs to have the analgesia first to actually decrease the amount of pain that's actually there? Or do we actually have to actually go down the lines of actually saying it's not just that particular localised pain, it's an overall pain management we need to actually do? Catecholamine the symptomatic picture is increased heart rate, increased systemic blood pressure, increased sweating, nausea, and the headache that's actually going to have to be there too. One of the things associated with Irukandji syndrome is the Irukandji syndrome, the patient will remain as a GCS of 15. or thereabouts. Anything associated with a decrease in GCS, it's probably not an Irukandji syndrome invoked. Think something else. Decrease in GCS, think something else. The increase in intracranial pressures associated with potential for a bleed, an intracranial bleed, are quite low when it comes to Irukandji syndromes. The treatment associated with Irukandji syndromes, it is a process of ensuring you actually manage the patient's pain. That is the biggest significant point here. If you can manage the pain and the patient becomes more cooperative, then you can go down the lines of actually making sure you've got different types of clinical management. You can actually do, we'll talk about those as well. If the patient's actually willing, can you actually give them some Panadol and ibuprofen just to actually decrease that pain? So you're actually giving them that systemic analgesia as well. Severe agitation, I've actually mentioned before, you may not actually be able to get that to actually come through with the IV access, but if you can actually get cooperation on the patient utilising intranasal fentanyl or actually utilising IM fentanyl in the first instance, it may actually be beneficial. I mentioned here on my board, I've actually got, let's discuss fentanyl. A couple of reasons associated with fentanyl actually utilised as the first option is that fentanyl actually has a sympatholytic effect. If you think about your sympathomimetics actually increase your heart rate. It's the adrenergic stimulus you actually get. It's the glutamate, it's the dopamine, it's the noradrenaline and the adrenaline effects we actually get. Fentanyl actually has a sympathomimetic, so sympatholytic effect. So sympathomimetics are going to increase, sympatholytics are going to actually decrease. If you have the ability to actually decrease the available catecholamines that's actually being released, then you'll actually decrease a number of factors associated with that physiological response. We say fentanyl over morphine in the first instance because of that sympatholytic effect. We also go down the lines of ensuring that we actually have a shorter half-life. The potential is that these patients are going to have a significant reliance on us to actually give them a huge amount of analgesia. They're in a significant amount of pain because, as we know, the neocytes or the nemocytes associated with the Irukandji is that they'll actually continue to fire off even though the tentacle's actually been displaced or it's actually been taken off of the jellyfish itself. If you haven't got fentanyl, then yes, go for your morphine. But remember that the morphine has a couple of effects. Morphine has more of a histaminic release. It also has a decrease in your blood pressure. It has a longer half-life as well. The fantastic thing about morphine is that it also has an anxiolytic effect that may actually be beneficial to the patient. IV magnesium. We talked about IV magnesium currently for St John NT is that it is an ICP skill. When we actually talk about it, magnesium is an antagonist to calcium. That will actually mean that if you actually feed a cell calcium, it is a doing thing. So smooth muscle relies on calcium to actually to constrict or to move. If you have that ability to actually antagonize that calcium by utilizing magnesium, then you have that ability to decrease the smooth muscle movement or the smooth muscle contraction. If that's the case, then you can actually decrease your blood vessel vascular wall and actually cause that vasodilation. That also comes along with the GTN. GTN, we currently in the Northern Territory do not actually have GTN as a infusion. It's only actually utilised as a spray, sublingual spray, and also a topical patch that we actually utilise for our patients as well. If the patient does actually go into a cardiogenic evoked APO, or acute pulmonary edema, CPAP is actually indicated for this particular patient. But remember is that when you're using CPAP, currently with no infusion, the GTN is that you will actually, when you remove that mask, is that you're actually going to lose the alveolar recruitment you've actually tried to create because of that increase in pressures, the constant pressures associated with thoracics. It only is going to actually be a small dip, but the potential is that once you actually put that mask back on, you'll actually increase and actually retain that or get back that alveolar recruitment. But remember, every time you actually take that mask off, it's going to actually decrease. So the other thing too is that we want to make sure that we actually monitor our patient. So ischemic changes associated with tachyarrhythmias or tachycardias can actually be seen in Irukandji syndromes. If that's the case, you just need to make sure you're actually looking at that to see if it's not just cardiogenic or it's actually because of Irukandji syndrome. The last point is that we actually talked very much about the use of urine, and it has been on television, it has been in the past, that if you don't have vinegar, you actually get family to actually wee on the patient. There's issues associated with that because the potential is that it actually does increase the mnemocyte in firing associated with urine. I don't know how and I don't know why, but they're actually saying don't actually utilise the urine, go for the vinegar in the first instance of the first aid, then actually go down the lines of actually utilising your ALS and your ICP skills. I'm Paul, I'm the clinical instructor for the ICPs within St John NT, and that was Irukandji Syndrome. Thank you.